All right, we'll give everybody about a minute to join in. I think we have 4 people so far. We'll give everybody a minute so that way we can get started. How's everybody doing tonight?
Good, doctor. Thank you. And how are you feeling?
I feel better. It's that that virus that's going around. My grandkids had it, and then my daughter had it. Then I got it. It doesn't feel good. All right. So I was looking over tonight's lecture, and it looked like we had cardio and diabetes. I don't think we're going to be able to get through both. So I'm going to move, and I see we have an open date coming up where there's nothing on a Wednesday. So I'm going to put diabetes on that day because cardiovascular is pretty extensive. So I want to make sure we do cover cardio and you understand it. So, all right. All right. We're going to go ahead and get started. And if I have to let somebody in, I will. All right. Did everybody get a chance to review the cardio notes?
Yes.
All right. Okay.
I not understand most of them.
Good.
I did.
Good.
I did.
That's why I'm here. So by the time we finish today, you should be able to teach it to everyone. That is the goal. Okay. All right. Okay. So I guess the only mic is Dr. Rosales. I hear Dr. Rosales. That's the only mic that's working today. Dr. Pena, I see yours. I see you're turning it on, but nothing's coming out. Dr. Young?
Yes.
Okay, good. Yours is good. Okay. All right, so we got Dr. Young, Dr. Rosales.
Hello?
Yep, I got you now. Yep, I can hear you. Okay. Dr. Lazo. Dr. Saul. Okay.
How are you feeling, Dr. Sutton?
Good evening. Good evening.
How are you feeling?
I feel much better.
You sound better too.
Yes, much better. So, all right. So let's go ahead and jump right into our fun day today. And we're going to be looking at the cardiovascular system. And the cool thing about this, the cardiovascular drugs, is that if you really understand the physiology of the cardiovascular system, it really does make sense, okay? And so what I want to do first is I want to give you the big picture, right? Let's see, let's go up here. So I want to give you the big picture. So whenever we're talking about the cardiovascular system, right? What is tell me, I guess the first question is, when I say cardiovascular, tell me what I'm talking about. What do I mean when I say cardiovascular? Anyone?
Heart.
I mean heart. What else?
Vascularization, blood flow to the heart and muscles.
Okay. Okay. Good. Perfect. Yeah. So blood flow. So we're talking about blood flow in a systemic fashion, right? So blood flow throughout the entire body. And so if now that's the big picture, right? So would you all agree that if something compromised that flow, that could change, you would need some type of drug to correct it. So watch this. So the drugs that we're going to be talking about are going to be addressing a few problems. What are the reasons for hypertension? Give me reasons for hypertension. Physiological reasons.
Obesity.
What would you say?
Obesity.
I could bear. Say it one more time.
Fat people. Obesity.
Obesity?
Yes.
Okay. That obesity is a cause, but I'm looking more for a physiological reason. So I'll give you the first one. One reason for hypertension is increased blood volume. Okay, that's one reason. What's another reason?
Endocrine disorder.
Be more specific.
Hyperthyroidism.
Hyperthyroidism, that would increase your heart rate. Yeah, but why would your blood pressure go up?
Because the blood flow is increasing inside it. It needs more blood flow to keep up with it.
Nope, that's not correct. Not quite.
Uh,
Just because you have an increased heart rate doesn't mean your blood pressure will go up.
that is vasoconstriction of the vessels.
Oh, I love that. Increased vasoconstriction. Yes, that's a physiological reason. Okay, I like that. How about increased viscosity of the blood? Would that make it go up?
Yes.
Okay. Now, believe it or not, right? Believe it or not, every single thing that we talk about today is going to be linked to one of these three causes. Isn't that pretty cool? That every drug that we talk about, we'll be able to connect it to either blood volume, vasoconstriction, or viscosity of the blood. Everything. And so as we go through this, I'm going to ask you to make sure you're able to make those connections. Okay? So don't forget blood volume, vasoconstriction, viscosity of the blood. Now, before I go to those, let me explain this. If you have a blood vessel, right? Here's your blood vessel. If I increase the volume of blood in that blood vessel, right? You all said that would cause it. Was that somebody? I thought I heard a bell ring. I think I did. Hold on 1 second. Let me make sure there's nobody trying to get in. Yep, there he is. Okay. Uh-oh. Did I delete that? I did. Okay. All right. So here's the blood vessel, right? If I increase the volume, right, in that blood vessel, what essentially is causing the blood pressure to go up?
The amount of blood.
Yeah, but why? So there's a formula. It's called pressure is equal to force over area. All right. Have you all seen that before? So what this basically means is this. In order to know that there is some type of pressure, there has to be a force that's pressing against the vessel. If there is no force pressing against the vessel, then the pressure is going to register as low. Does that make sense?
Yes.
So just like you said, increased volume is going to put more pressure on the walls of the vessels, which makes your blood pressure go up. That makes sense, right? Now watch this. Somebody mentioned vasoconstriction, right? Now look at this. If you have this blood vessel, right? This looks like vasoconstriction compared to the other one, right? Now, what if we had the same amount of blood going through this vessel that it was going through that? The same amount of blood going through that vessel as it was. This is A, this is B. If we had the same amount of blood that was in A trying to go through B, would that be high blood pressure?
Yes, doctor.
Yes. Why?
Because the amount of pressure will increase. The blood going through the surface area is much smaller.
So the surface, so you're saying the surface area is smaller.
Yes.
And so it's going to have the same volume, which is basically going to put more pressure on the walls of the vessel.
Yes, doctor, exactly.
Very good. Exactly. Watch this. What if I increase sodium intake? Dr. Young, would that increase your blood pressure?
Yes.
Why?
Because it's harder for the sodium to get through, the calcium to get through.
No, that's not. Think. Okay, now, so you remember I told you I was going to always go back to those three things, right?
Mm-hmm.
What three things did I tell you everything is linked to? What's the three things I said? They're linked to three. Everything we're going to talk about tonight are linked to three concepts. One was increased blood volume. What was the second one?
Vasoconstriction.
Vasoconstriction. And the third?
Viscosity of blood.
Okay. Everything is related to that. Okay. So Dr. Young, remember so you heard those three, right?
Increased blood volume, vasoconstriction,
and viscosity of the blood. Okay.
Mm-hmm.
So my question is, if I increase sodium intake, would that increase blood pressure? You said yes, I agree. And I said, how?
Would the viscosity of the blood change?
It could, but not enough, because you already got sodium anyway. So it's not going to be viscosity would go more. Well, the answer to that, really, no. That's not the primary reason.
It would increase the blood volume then.
Why? You are correct.
Is it because it'll make it seem heavier than what it is?
There's a concept that starts with the letter O. Yes, say it. Don't run from it. Say it.
Osmosis?
Yeah, of course. You got to believe in your it's in your mind. Don't second guess yourself. So what is osmosis?
The diffusion of water.
The diffusion of water from where to where?
From a higher concentration to a lower concentration?
Think about it. Think about it before you say it. Just think about it. What is diffusion? What is osmosis? Diffusion of water from where to where? Well, let me ask you a better question. Have you ever had a margarita?
No.
Good. Now, you don't have to, we're not going to judge you if you've had one before. But let's just say you had a strong drink, okay?
Mm-hmm.
Now, if you had a very strong alcoholic drink, how would you make that weaker?
You add more of a chaser, right?
Well, you would add water.
Okay.
That would make it more dilute, correct?
Yes.
So we're adding water to a more concentrated or less concentrated substance.
You're adding it to a more concentrated substance.
Exactly. Very good. So you see this sodium that's in the bloodstream?
Mm-hmm.
That's your margarita.
Okay.
Where do you want water to go?
To that or within that.
So you want water to go in here?
Yes.
Okay, so water goes in there. What happens now since water goes in there?
You want the sodium to go out.
No. Oh. What happens now that you're increasing the water in here? What's the result?
you have more of a balance of the mixture.
No, stop, pause, and think about what I'm asking. I told you everything is linked to 3 concepts.
Oh, you decrease your blood volume.
Yes. If you increase your blood volume, what's going to happen to the pressure?
It's going to go down. No, but if you're increasing it, you said increase, it's going up.
That's right. You understand that?
I believe so.
Explain it to me again, man. Prove it to me. Prove it to me. You understand it.
Okay, so for your blood pressure.
Now, I'll start at the beginning from sodium intake.
Sodium intake. So you have more sodium in your blood is why you have high blood pressure. So in order to lower that blood pressure, you're going to have.
See, that's why I love being able to talk and hear. See, a lot of times when people take an online class and it's just recordings, the recording can't tell you to stop, can it? No. Okay, so the question I'm asking is, why does sodium intake increase your blood pressure? That's the question I'm asking. And you know it. I guarantee you know it. I promise you know it.
It increases your blood. The volume of it?
Yep. Say it with confidence.
It increases the blood volume.
Yep. And?
Makes your blood pressure higher.
Exactly. Is that straightforward?
Okay.
Is that straightforward? Does everybody understand that?
Yes, doctor.
Yes, doctor.
Okay, perfect. Okay, now watch this one. Let's see. Dr. Agnes. All right. Will increased glucose, Dr. Agnes, increase your blood pressure? Is Dr. Agnes here? Okay, no. All right. Dr. Lazo?
Yes, doctor.
All right. Will increased glucose increase your blood pressure?
It would increase because it's protein. No, it's not protein, it's sugar. So would that increase the viscosity of the blood?
Okay. All right. That's right. Exactly. So when you increase glucose, you increase the viscosity of the blood, which basically makes the blood thicker, right?
Right.
So when the blood is thicker, it doesn't move through as fast, right?
No.
So that means it's going to have more time to push against the walls of the vessel, because that's the only way we know that pressure is high, right?
Right.
Very good. Okay. All right. Everybody understand glucose?
Yes.
Yes, doctor.
All right. Now, since that was the physiology of what we needed to know first, I guarantee you everything that you learn from this point forward is going to fall into that. Okay. So in terms of the INBDE, right, there are different cardiac conditions that they will test you on. But watch this. You're going to love this. All right. Congenital heart disease, right? What do I mean by that, Dr. Saul?
Heart diseases or heart defects in the newborn.
Perfect. What are some common ones in the newborn?
Just give me a second. Related to patent ductus arteriosus is one of them.
Yeah. So a PDA, patent ductus arteriosus. What is that?
Something related to blood flow from left to right. Something I don't recall completely, but something related to left to right.
Okay. So that's true. So basically what that means is, so basically whenever the fetus is there, they don't have any lung capacity, right?
Yes, yes.
And so there's a little hole that basically shunts the blood, like you said, from left to right. Well, when the baby takes their first breath, that hole closes. That's normal. If it doesn't close, we call it a patent ductus arteriosus.
Right.
Good. Very good. All right. Good. What else?
Tetralogy of Fallot, doctor. Is that right?
Yep. That's definitely congenital. What's the four things related to tetralogy?
Oh my goodness.
There's a mnemonic.
I remember Dr. Ventral septal defect, if I'm not wrong.
Uh-huh.
I don't know the
Okay.
name.
You know what? Don't even, just that you knew it, that's enough. Perfect. Good. Okay, good. You can mute your mic. Perfect. Great job. And we'll talk about some of those congenitals in just a second. All right, hypertension. We already know that. Hyperlipidemia, Dr. Rosales. Would hyperlipidemia increase your blood pressure?
Yes, doctor.
Why?
Because we have lipids on the blood and will be increase the viscosity. No?
That's true, but not the primary reason. You're right, but there's another one of the three that's a better choice. What if you're right, if those lipids, so basically what you're saying is this, right? You're saying that basically you get these lipids to the deposit, right?
Yes.
On the walls of the vessel. Okay. So what reason would the blood pressure go up?
Because will be more pressure on the vessels, on the walls.
That's true. That's true, but that's true. So what happens to the area?
Will be smaller.
Yes, right. So that falls into that vessel being more constricted.
Yes.
You see that?
Yes.
Because it's more narrow. Okay, good, perfect. All right. Let's see here. Dr. Pinna, what is angina?
Chest pain.
But what is it? Why?
So it's basically related to the heart trying to increase the pressure in order to have the blood flow. So basically, it's viscosity of the blood.
No, it's not that one. It's another, something else. Not so eliminate viscosity, so you're only left with two.
So blood volume.
Nope, you only left with one.
Vasoconstriction.
Right, there you go. So angina basically is a vasoconstriction. That's so you're talking about the coronaries, right? The coronary arteries.
Yes.
And so basically what's happening in angina is you're getting a vasoconstriction of those coronary arteries. So that's what angina is. Now you're right in your description. It's going to cause you chest pain, stuff like that, but it's due to that vasoconstriction. Okay?
Yes, doctor.
All right, good job. All right. Dr. Let's see where we're at. Back to Dr. Young. Dr. Young, what is congestive heart failure? Dr. Young?
Isn't it like more chronic?
Now, you started off by the word, isn't it? Isn't it sound like you're asking me a question? You want me to answer it?
Yeah. I'm not sure, but I think so.
You think what?
It's chronic. It's more chronic.
No. What is congestive heart failure?
It's
like, what's happening?
It's like really bad when your heart doesn't pump like it's supposed to.
Thank you. That's what I'm looking for. Pump not working, right? Now, when I say the pump is not working, you follow me so far? That means blood is not going where?
To the rest of the body.
Good. So you're going to have decreased blood to the body, correct?
Okay.
Okay. Follow that. Right. Okay, good. Very good. Okay. Dr. Rosales, what is bacterial endocarditis?
It's a bacterial infection of the heart.
Yep. Which valve mainly?
Which valve?
Yep. Which valve in the heart is the main one that's normally affected by bacterial endocarditis?
I'm not sure, doctor.
Okay. It's called the mitral valve.
Okay.
Also known as the bicuspid. Okay.
Yeah.
And what two bacteria are the main causes of endocarditis?
What do the bacteria, you say?
Yep.
They will be affecting the function of the heart.
Right. But there are two bacteria that are the major causes of the endocarditis. And I've already listed them. What are they?
The streptovirus and the I can't read.
Staph aureus.
Okay.
Yep. So those are the two causes, but we'll talk about those in just a second. Okay. All right. So let's go ahead and jump right into this. All right. So just like Dr. Saul mentioned earlier, one of the congenital things we see with tetralogy or congenital is tetralogy of Fallot. And the mnemonic is PROV.
Oh.
That's the mnemonic for tetralogy of Fallot. So pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and VSD. Now, if you look at this is called like the blue baby syndrome, cyanotic. So the babies are blue. Why are they blue? Anyone?
Because of pulmonary stenosis.
Because of what?
Not enough oxygen.
Not enough oxygen. And I think somebody said pulmonary stenosis. So basically, if you have a pulmonary stenosis, then you're going to be blocking the oxygen release, right? Perfect. Very good. Now, if you blocking the blood flow to the pulmonaries, what's going to happen to the right side of the heart?
It will become congenital. It will stop pumping.
No. Think about what I asked. Think about it. If you block the blood flow to the pulmonary system, what is going to happen to the right side, the right side of the heart?
They become hypertrophied.
Exactly, because it's going to get bigger because the blood flow is not being able to get through. Does that make sense to everybody?
Yes.
Okay, good, perfect. All right, the other thing is what we call the PDA, patent ductus arteriosus. That's the one I mentioned earlier about when you take your first breath, that closes. If it doesn't close, you have a patent ductus arteriosus. Okay. All right.
Doctor, usually PDA also gets detected later on in the life as well, right?
Oh no, PDA. Think about, well, a PDA can if it's mild.
If it's mild, okay.
Yeah. But typically, you think about it like this: if you have a major PDA, then that PDA is going to show up quick because now you're shunting blood from the right to the left. You're shunting deoxygenated blood to your tissues.
Makes sense. Yeah.
Which you're going to be walking around with cramps and fatigue and everything else. If you make it to that point. But typically they can see that on a pulse ox. You can do a pulse ox on a baby or anything and see whether or not the oxygen levels are normal.
Okay.
Okay.
Thank you.
All right. So here are some congenital things just to look at. So individuals with Morphans. So with Morphans, they are associated with aortic dissection. Okay, that basically means the aorta, which is one of the strongest vessels in the body, it literally splits. That happens with Morphan syndrome. Now, Morphans is a deficiency in a protein called fibrillin. Okay, fibrillin, and you can remember the F in Morphans for fibrillin. And the way that the individual looks, they look tall. They have very long fingers, long arms, okay? That's Morphans. Don't get that mistaken with something called Ehlers-Danlos syndrome. I like to think of Ehlers-Danlos syndrome as the, you ever watch the, what's that, the Fantastic Four? It's like a comic thing, and they have the stretchy man. You know what I'm talking about?
Yeah, the Elastic Man.
Yes. That's Ehlers-Danlos syndrome. So you see that E, that's elastin. Okay, so that's an easy way to remember that. Okay, all right. Down syndrome. The common heart defect with Down syndrome is a VSD. All right. Turner syndrome.
Doctor, I have a question.
Yes.
With Marfan's syndrome, so will Ehlers-Danlos syndrome will be the differential diagnosis, like a DD for this?
Yes. Yeah,
Okay.
absolutely. Okay. But Ehlers-Danlos syndrome doesn't give you the aortic dissection.
Yes.
Right. And the other differential is the fibrillin and elastin. So those are two things that if they say fibrillin, you know they're talking about Marfan's. Okay. All right. Turner syndrome is coarctation of the aorta. What that means is if you look at the aorta, say this is the aorta right here, right? Coarctation of the aorta means you're basically pinching the aorta at a certain spot. Right after the descending aorta starts, you squeeze. If you put your finger around the around the vessel of the aorta and you squeezed it, that's called coarctation of the aorta. You're squeezing it at that one point right there. You see that? That is Turner syndrome. Turner syndrome is XO. Okay, XO equals CO, coarctation. Now, Down syndrome is trisomy what?
21.
Perfect. Very good. Trisomy 21. So Down is trisomy 21. Perfect. What is Edwards?
Trisomy
what? 18.
8.
And what is Patau? That's going to be trisomy 13. So if you ever forget, just in case this ever comes up, the legal age to drink is what?
18.
21.
Yeah. No, most places is 21.
21, okay.
21, all right. And what's the age that you can elect a president?
18.
18.
There you go. So that's you electing a president. And puberty, we typically say starts at what?
13.
Yeah. So everybody understand that?
Yes, doctor.
All right, perfect. Okay. All right. So we already talked about, like we talked about hypertension, the reason you could get it, right? And I think Dr. Rosales told us earlier that you can, causes or risk factors is like obesity. Smoking is a risk factor for everything. Okay. I don't care what it is. They say which of the following is a risk factor. If smoking is listed, of course, smoking is a risk factor. Okay. So let's go here. Okay. Blood pressure. So let's see here. All right, Dr. Penner, what is the blood pressure at which you would not treat a patient?
Oh, anything above 180. Basically,
Okay.
140 is not good.
Okay. So say for instance, you had a patient that came in with a blood pressure of 175 over 84. Would you treat him?
I will tell him to drink his hypertensive medication, wait a little bit, and if it doesn't decrease, no, I cannot treat him.
Well, I thought you told me over 180.
Even though anything above 130, that's already hypertension, like in critical stage.
130, that's critical. You sure?
140.
Okay. Does everybody agree with that?
Well, I'm kind of confused because is this up to date? Because I thought we couldn't treat anybody at 160 over 100. That was like the cutoff for anything.
Okay. All right. So you said how much?
160, and it has to be lower than 100. Like it has to be below that. Like that's too high.
Okay.
So if it's like 159 over like 95 or something, you can do it, but you still need to document it, and you still need to refer them to their doctor.
Correct. So from this table here, let me show you what you're looking at. So we already know that hypertensive crisis is 180 and over 120. What that means is you need to be calling someone right away. They need to actually go to the hospital. All right. Now that's them needing to go to the hospital. If they are, look at this range right here, 140, and the number that I just gave him was 170, right? I think 170, 175. And then you see this 90 or higher, which 100 falls into that category, right? So basically, what the safe thing to do is that normally if the blood pressure is stage 1, then what do? You typically have we have white coat syndrome, right? Everybody know what white coat syndrome is?
Yes.
What is that?
You see a doctor and you faint, or your blood pressure goes high.
Good. So what do you do for a patient that in that case?
You let them rest for a few minutes and you retake it. If not, you refer them to their doctor.
Very good. Exactly. But that typically, when we say that, you do white coat for anybody that is not at the critical stage. Does that make sense? Critical meaning higher than 180, higher than 120. Does that make sense?
Yes.
Yes,
But if a patient is, say, 140 over 90, right? If they're there, then you let them wait a minute, and then you want to see if that blood pressure goes down. If it's not, if it's consistently above this number and the bottom number is 100 or higher, then of course they're going to have to be referred to their physician. Does everybody understand that?
Yes.
Yes.
Okay. All right. Perfect. All right. Let's see here. Dr. Agnes, are you here? Do you see?
Here.
You are. Okay. So Dr. Agnes, tell me about this. Answer this question for me.
Okay. So, starting off cutting metformin because it's not gonna be.
Wait. Before you do anything, how do I like you to tell me what the question is asking?
So, what should I give a patient with hypertension?
Okay. With any hypertension. Okay. All right. That's fine.
So,
And
all
all right. So tell me what you eliminate.
Metformin, is that for diabetes?
Okay. So you want me to get rid of that. Okay.
Procainamide. Amide is for cholesterol.
You sure that's what procainamide is for?
Amide. No, it's no. I would go with lisinopril, with the ending of pril.
What does pril mean?
That's for people with hypertension.
But what is Pril? What kind of drug is that? Well, don't worry about it. Don't worry about it yet. We're going to talk about it.
Okay.
Why did you eliminate alprazolam?
Because that's for the stomach. Ish.
You sure about that?
Yeah, alprazolam.
You are sure that's for the stomach?
Or for sedation?
Okay, like anxiety?
Yes.
Panic disorders?
Yes.
What class of drug is that?
So an opioid? If it's for anxiety, let me
wait, hold on, stop right there. Okay. All right. What I want you to do is I want you to just relax for a second, okay? Now, let me ask you a question. Have we covered opioids?
Yes.
Okay. And I want you to think, when we covered opioids, do you remember us talking about alprazolam?
No.
Okay. So you follow, you see what I'm talking about?
Mm-hmm.
That's what I want you to do when you're at the test. Because a lot of times, like when you're put on the spot, it's like you have so many thoughts in your head, right? And you have to kind of narrow them down. So what I want you to always do is just kind of go back and say, okay, let me think. Well, I know it's not an opioid because we didn't talk about that. So it wouldn't fall into that category. But that would help you on the test because you can eliminate opioids, right?
Yeah.
Okay. So, but do you know the category of drug?
I know the ending.
Okay. All
right.
All right. That's fine. Well, you got the right answer. Your answer is right, and we're going to talk about that. But I'll just ask the group. Anybody know what alprazolam group drug is?
Benzodiazepam.
That's right. Benzodiazepam. What about procainamide?
Anesthetic. Amide.
Are you? Wait a minute. No, you sure about that?
Procaine is ester. It's
no.
Yes,
I think y'all getting them confused. No.
Oh, it's not an anesthetic. Sorry.
It is not an anesthetic.
No, it's not an anesthetic.
No.
It's antiarrhythmic.
Yes, good. Thank you. That's right. It's an antiarrhythmic.
And Dr. Lisinopril is ACE inhibitor.
That is true. That is an ACE inhibitor. That's right. That is an ACE inhibitor. Very good. And then metformin is what we call a biguanide.
Yeah, for diabetes. Yeah.
Correct. Okay, good. Perfect. All right. Okay. Okay, let's see here. Let's see. That was Dr. Agnes. All right, Dr. Saul, this is your question.
So the question states that...
That's the same question. Oh, no. Sorry.
Okay.
I think the options are the same. The question is different.
That's right.
So the question asks, which of the following drugs acts by increasing the refractory period of cardiac muscle?
Yep.
So the answer is again lisinopril, doctor, because rest all we already did. Alprazolam is benzodiazepine, metformin is for diabetes, and procainamide is antiarrhythmic.
So I want you to think about your answer again.
Oh, you're right, doctor. It's procainamide. It's antiarrhythmic. So it's
okay.
Yes, it's increasing the refractory period of cardiac muscle. Not
yes. So make sure before you answer, think about it first.
Sorry.
Right. Okay. Because that is an antiarrhythmic.
Yeah.
Okay. All right. All right. Let's see. That was Dr. Saul. Dr. Lazo, this is your question.
Okay, it's asking about patient indicated swelling in the lower extremities, which is I can see the right side. Which medication would be most beneficial for this patient with lower extremity swelling? Hydrochlorothiazide, that's an HCT. And that works in the leukopenny. Propranolol is for the heart, beta blocker. Ephedrine could be an opioid. Amiloride is, would it,
All right. So before you give me your answer, we're going to make sure you do it according to my test taking strategies. Okay?
Okay.
All right. Now, step one of my strategy says you do what? You read the question.
Read the question first. Yes.
And put it in your own words.
Yes.
So what is the question saying in your own words?
It's asking me what would be the best or beneficial for the, oops, that would help treat the swelling of this patient.
Perfect. Very good. That's what you know, right?
Right.
Okay. Do you know why? Can you tell me what is the swelling? What is that called?
It's caused by
What's the name of that swelling? What is it called?
edema.
Very good. It's called edema. So what you're saying is so you want to know the best treatment for this patient's edema, right?
Correct.
What is the reason for, oh, no, I'm sorry. I'm giving you too much information. Okay. So what do you do next? So you put the question in your own words. Do you know the answer right away? It's either yes or no. I think I heard somebody click in. So that's going to give you, the good news is going to give you a second to think about what I just said.
Okay.
Okay, no. Okay. Oh, I thought somebody, nope, that wasn't them. Okay. Okay. All right. So do you know the answer right away?
I would say yes.
Wait.
It would be A.
Okay. Now, you know that. Now, if you know it, you pick A and you keep going. You don't worry about it. So,
Correct.
So before, why didn't you just pick A immediately? Why were you going through the answer choices?
Because I see per panel, that kind of throws me off.
Why?
And because I know it's a heart condition, and I had to think if propranolol as a beta blocker doesn't have anything with the water retention, and I knew then that the HCTZ has something to do with the sodium uptake and water retention. And
what is hydrochlorothiazide?
Hydrochloric thiazide is a diuretic for high blood pressure.
Okay, very good. It's a diuretic. Okay, good. What is propranolol?
It's a beta blocker.
Very good. What is ephedrine?
Is it an opioid?
Now, doctor,
Yeah.
did we cover opioids?
Yes, we did, and it didn't.
And you don't remember seeing ephedrine in opioids, do you?
No, I didn't.
Why do you all love opioids so much?
Because it was so much fun of a lecture. Sorry.
Okay. So look at the word ephedrine. What does it look like to you? If you had to guess, and it ends with NE.
NE. Something to do
with what?
Heart.
Okay, that's true. It's more so the CNS.
Okay.
It's a CNS stimulant. So when you see ephedrine, you should think norepinephrine. See how it ends with that NE?
Right.
Think like norepinephrine or a sympathetic drug. Okay. Now, what do you think that ephedrine would do to your blood pressure?
Increase.
That's right, because it's a sympathetic drug, right?
Correct.
Very good. All right. What's the Milleride?
A Milleride. It's also it is also a antihypertensive.
It is.
But it doesn't work as the HTZ. It works as a something with sparing.
There you go. It's a potassium sparing diuretic, right?